Hello, welcome to How to Get Beyond Better to Feeling Your Best. My name is Ceciel Rooker, and I'm the President and Executive Director for the International Foundation for Gastrointestinal Disorders, or IFFGD. IFFGD is a patient education and advocacy nonprofit organization that our mission is to inform, assist, and support people affected by gastrointestinal disorders. Here with me today is IFFGD board member and gastroenterologist, Dr. Darren Brenner. Welcome, Darren.
Thanks, Ceciel. Thanks for having me.
Absolutely. Dr. Brenner is not only a member of the board of directors for the International Foundation for Gastrointestinal Disorders, but he's also the butts and guts guy at Northwestern University, where he is a professor of medicine in Chicago. He specializes in the treatment of gastrointestinal motility disorders and pelvic floor disorders. These include constipation, fecal incontinence, irritable bowel syndrome, dyspepsia, gastroparesis, opioid-related bowel dysfunction, as well as complications from systemic motility disorders with an emphasis on scleroderma, as well as many other GI motility disorders. We are so pleased to have him with us today during our Constipation Awareness Month program. So as you all know, December is Constipation Awareness Month. And throughout this month, we're going to have this program on Beyond Better to Getting to Feeling Your Best, really focused in on constipation predominant irritable bowel syndrome. And we hope that throughout this month, we will be able to educate you so that you can get beyond, I feel better, to really feeling your best. And in order to do this, we're going to walk you through first, what is constipation predominant irritable bowel syndrome? That was episode 1. I hope you were able to watch. And then talk about symptoms, which we did in episode 2, which was last week. But we also need to talk about communicating with our healthcare provider to get diagnosed and treated, right? And so today we're going to talk about the healthcare provider visit. Now that we know what it is, and we're thinking maybe I have that, and then Dr. Brenner talked about symptoms, and we're like, okay, now I really think I need to talk to my healthcare provider. So you schedule that appointment. And once you get to the appointment, Dr. Brenner, what can they expect?
Sure. So I think first and foremost, we're going to ask if we know you're coming in for constipation, what your predominant symptoms are, but most importantly, when they began, to try and get a time frame and an idea of how long this has been going on. Then we're going to ask the textbook symptoms, like we talked about in the other 2 episodes: frequency, texture, straining, incomplete evacuation. I mentioned in episode 1, I'm hoping that they will ask about associated abdominal symptoms like pain, discomfort, bloating, and distension, because this necessitates a different type of treatment. And then we want to know a little bit about potentially a trauma or abuse history, because that can play a role as well. Obviously, the goal is to determine what type of constipation if you have, and if it's irritable bowel syndrome with constipation, in many cases, after a quick physical exam, which will in many instances include a digital rectal exam, and we can come back to that and talk about that a little bit more later, we will go directly to treatment. Most of the societies recommend going straight to treatment if you meet criteria for irritable bowel syndrome. So there should not be these big, long gaps or delays between seeing us the first time and actually having some sort of therapy to hopefully get you feeling better.
Fantastic. All right. So you said we're going to circle back to the digital rectal exam. Before we proceed, tell us what that is.
So this comes down to the understanding that, and for many people, irritable bowel syndrome with constipation does not necessarily occur in a vacuum. There are many different types of constipation, and there's a significant amount of overlap between irritable bowel syndrome with constipation and a disorder called dyssynergic defecation or functional defecation disorders, pelvic floor dysfunction, and anismus. I throw all of these terms out there in case you've heard of them. But at the end of the day, what they all mean is the stool makes it down through the colon to the bottom, but there are a couple of muscles at the bottom, and these are skeletal muscles. They're made up by your external anal sphincter, another muscle called the puborectalis. And these are under volitional control. You control when they squeeze really tight. If you're in the middle of the mall, you get the urge to go to the bathroom, there's no bathroom, you squeeze these so that nothing comes out, but you should also be able to relax them. And in many situations, individuals are not able to relax those muscles. So when we do a digital rectal exam, that's what we're doing. We're looking at the functionality of those muscles. Our finger goes in, we'll ask you to do some squeezing and some pushing, and we're trying to determine if these muscles work. Because if these muscles are ineffectual, a lot of people come in the office and say, after we talk about this, well, Dr. Brenner, do I have irritable bowel syndrome with constipation? I'll say, yes, but it's not the rate limiting step. Because if the door at the bottom doesn't open, nothing is going to come out. And because that door is made up of skeletal muscles, we treat it completely differently, specifically with pelvic floor physical therapy and biofeedback. So that digital rectal exam is the first indicator that maybe something other than irritable bowel syndrome or a transit issue is present, and we need to address that concurrently.
Absolutely. And as you mentioned, there could be overlap. So there may be treatment of both of those disorders at the same time down the road. Absolutely. So, okay. So we've been in, we've sat down, we've answered all of the questions. We've told you how this is affecting our life, right? We've talked about our history. We've gotten our digital rectal exam. Now, a lot of times doctors may order tests, right? So there may be some testing involved just to make sure that we have ruled out things, or we've decided on some things. What are some tests that we might expect a healthcare provider to ask us to undergo?
So I'm hoping that your provider will minimize the diagnostic testing, okay? As somebody who sees complex cases at Northwestern, I see young people come in, I see older people come in who've had 5 colonoscopies and 10 CAT scans and 2 MRIs and every blood test you can think of and motility testing. And at the end of the day, the societal guidelines in the United States, the American College of Gastroenterology, the American Gastroenterological Association of America are pretty much in agreement with this. And we recommend what we call a positive diagnostic strategy, minimizing studies. So some people will order a CBC to make sure there isn't an evidence of anemia or low blood counts or that you're bleeding, because that's an alarm sign or symptom. Other people will check your thyroid or your calcium, because if your calcium is too high or your thyroid is too low, you may have developed constipation. Certainly, if you're over the age of 45 or younger than 45 with a family history of colon cancer, we'll recommend some form of colorectal cancer screening. But outside of these caveats, what we recommend is nothing. If you meet the criteria for irritable bowel syndrome, we recommend that we go specifically to treatment. And if a few good evidence-based treatments fail, then we talk about some further diagnostic studies along a more motility spectrum than the standard test. We don't normally recommend CAT scans or MRIs, or people have what we call lower GI studies or barium studies or small bowel follow-throughs, or even breath testing. These are very expensive. Some are very invasive studies that really don't give us a lot more information that's beneficial. So if you see a practitioner who's recommending these, ask. It's your body, it's your life. Ask why these are necessary and what that individual is looking for.
Absolutely. So you mentioned that. So no testing, maybe in the upfront, but then if the treatments for IBS-C, constipation, predominant bowel syndrome, do not work, that the doctor may revisit that. So we should be expecting that if you go back and you're saying, I'm not feeling better, or I'm very, very minimally better, or maybe things have gone, I've got new symptoms, then the testing might occur at that point, but not necessarily after the first visit.
Yeah, that's correct. And there are a few tests that you should be aware of. The most common one, or the one that's most recommended, is a test called anorectal manometry balloon expulsion testing. And again, you may get this after the initial visit if your practitioner does the digital rectal exam and feels abnormalities to confirm that there is some of that pelvic floor dysfunction involved. If the physician or practitioner doesn't feel anything at that point, they may try to treat you, but this would be the most important test done if you're failing therapy. It's a very simple test. It seems strange. It's painless. We take a little catheter that's about 3 times the thickness of the tip of a pen. We put it in the bottom about the length of an index finger, and it has pressure sensors along its length. We're going to ask you to do some very simple things. Push, squeeze, cough. We're going to blow up a balloon and ask you when you feel it. Then we're going to blow up a little balloon with water and see if you can pass it. And as you're doing these physiologic maneuvers, the muscles we just described are going to put pressure on the sensors on the catheter. And that's going to create a little pressure map that we can read to see if the muscles are working correctly or not. And if they're not working, then we'll probably send you for some physical therapy or biofeedback. Now, if that test comes back normal or partially abnormal, not enough to give us a definitive diagnosis, then your practitioner may recommend a test called defecography, where a little bit of barium or barium and oatmeal paste is injected into the bottom. And using real-time x-ray, a radiologist is going to ask you to do the same things. Push and squeeze and try and pass that contrast. And this gives us, again, another assessment of the function of the muscles in the pelvic floor, but also the anatomy. When these fail, your practitioner may recommend what we call a radio-opaque marker test. And this is a little capsule that contains little rubber bands. You swallow it, and 5 days later, we get an x-ray, and we look to see where in the colon the rubber bands are, which can give us a sense of transit and whether or not transit is delayed. And these really are the major studies that we use to assess constipation on a regular basis.
Okay, so those are some things that we may expect, but not necessarily. It's not necessarily. It's not something that if you go to your doctor, these should be asking these. If they don't ask them up front, they may ask for them later. Be aware of that, but don't be alarmed if they don't. Absolutely. So Darren, let's say that you're having a conversation as a patient with your healthcare provider, and they want to talk about, what tests they may or may not perform. What are some things that we, as the patient community, should be thinking about mentioning, discussing? What are some things that are important?
Yeah, that's difficult because the studies really show that despite the fact that you have a lot of symptoms, we ask a lot of questions, there are no specific symptoms that are pathognomonic for one type of disorder versus the others. Again, one thing that we mentioned in the previous discussions is I want you to bring up the notion of pain. For many people, when they write on a form at the visit or they talk to the schedulers, they say the chief complaint is constipation. We focus on those bowel symptoms, but we really have to know about the abdominal symptoms, pain, discomfort, bloating, distension, because that should change the paradigm and the things that we recommend for treatment. So that's something we want to know. Again, we mentioned this in all the other ones. I want to bring this up again because it's so important. The quality of life impact. What are you looking for? Many patients come in and say to me, I have 3 bowel movements a day, 3 bowel movements a week. They're not perfect, but I could live my day-to-day life if. And it's that if piece that really addresses the quality of life that we want to focus on. So let us know. Let us know if we start asking about bowel symptoms, bowel frequency, bowel texture, what's going on in your abdomen, if there are other associated symptoms, and what these things are doing in terms of limiting your quality of life. Those are also major factors that may lead us in one direction versus another when we're thinking about further diagnostics and therapeutics.
Fantastic. Always important to be open and honest and to share with your healthcare provider. So that's all the time we have for today. Thank you, Darren, for your great insights on this and a little sneak peek into what to expect at that healthcare provider appointment. We hope that you at home have enjoyed episode 3 of How to Get Beyond Better to Feeling Your Best. As we've mentioned, this is Constipation Awareness Month. And so throughout the month of December, IFFGD will be talking about all things constipation. But in this specific program, this 5-part video series on Beyond Better, we're focusing on constipation, predominate irritable bowel syndrome, and how you can work with your healthcare provider to feel your best possible. Now, next week, we're going to continue this conversation and we're going to discuss treatment options. So we've talked about what is IBS. We've talked about the symptoms of IBS. We just talked about going with your doctor and seeing your doctor and what sort of diagnostics might be done. But what about treatments? That is really and truly what everyone wants to know. How am I going to get better? So don't miss out on next week's program as we talk about treatments for constipation, predominate irritable bowel syndrome. Again, thank you, Dr. Brenner, for your time, your dedication to patients in our community, and all that you've done for IFFGD. We really appreciate you.
My pleasure. Thanks for having me again.
Yes, and for those of you at home watching, please be sure to subscribe to our YouTube channel. I believe there's a button right there for you to click. And make sure that you check out all of IFFGD's other resources regarding the topic. We have a multitude of websites, not just our home website, which is IFFGD.org, but also one dedicated to irritable bowel syndrome as a whole, and that's called AboutIBS.org. And then one that is all things constipation, and that is AboutConstipation.org. So be sure to check out those resources when you have time to learn more about IBS, to learn about constipation, and of course, constipation predominant irritable bowel syndrome. We hope that you'll join us next week as we continue this conversation on how to get beyond better to feeling your best. Thank you so much for joining us.